In the next 15 minutes, I will be talking about the management of ocular surface disease. I have no financial interest to disclose. What is ocular surface disease? We all know it's a multifactorial disease where there's loss of homeostasis and balance of the tear film of the ocular surface, leading to tear film instability, hyperosmolarity, inflammation of the ocular surface, and neurosensory abnormalities. It's a common problem, and we face this every day in our clinics. It's probably the most commonly confronted condition. And we all know that the ocular surface is an integrated unit that has an anatomical, physiological, biochemical, a frequently overlooked mechanical component, and a very important immunological component. So, ocular surface disease can really affect the quality of life. It can result to ocular discomfort, visual disturbance, tear film instability, and potential ocular surface damage. And this can really make the person's life very miserable. So why is it important? It can lead to persistent epithelial defects, secondary microbial keratitis, and believe it or not, 1/3 of our patients at the cataract age are plagued with this disease. And it can be quite concerning if you're contemplating implanting a premium IOL, because ocular surface disease can itself induce high-order abrasions, and this is evident by corneal staining. Your patient can lose the wow effect after refractive surgery because it can cause a pseudo-refractive error. And what I usually use in the clinic is I use frequent lubricants post-refractive surgery if the patient is not 20/20, and the patient can improve 1 to 3 lines post-operatively with this test. It can also give false or abnormal keratometric readings, and this can reach up to 1 diopter, and this can be a cause of a refractive surprise of post-operatively. So who are those at risk? Basically, as we know, there's a quality and a quantity component to this. There's hypersecretion, and usually this is secondary to underlying systemic diseases. We have primary Sjogren's, and we have secondary Sjogren's, and we have all sorts of oncology and vascular diseases like sarcoidosis and what have you. We have hyperevaporation. Common causes are contact lens wear and abuse, meibomian gland dysfunction, low blinking rate, and so forth. With increasing age, this disease becomes more common. Females are more affected than males, and above 65% of patients do suffer from this disease. So the tear evaporation changes with age, the corneal sensitivity even changes with age, the cornea becomes less sensitive, and therefore the blinking rate is reduced, and there's inflammation and oxidative stress that increases with age. And age-related comorbidities and its medications can also induce ocular surface disease. Out of the 7 continents, Asians are more commonly affected by this. Infrequent blinking is a common risk factor, and refractive surgery or any corneal procedure can really increase the risk of ocular surface disease. Anti-glaucoma medications and preservatives associated with anti-glaucoma medications can increase the risk of ocular surface abnormalities. And I remember a number of patients that come to my clinic who have significantly severe ocular surface disease, just placing them on oral like acetazolamide for a number of weeks and treating the ocular surface, the surface returns back to normal. I refer them back to my glaucoma colleague, and then he says, okay, the ocular surface is clear now again, let's put you back on anti-glaucoma medications, and the cycle goes on. So how do we assess this? We all know there are different dyes. We can use lasmin green, rose bengal, fluorescein staining, and the Sherman's test, and the patient can fill out the ocular surface disease index while waiting outside the clinic. But how do we manage this? And this is the most important question of this talk today. We have to treat the underlying cause, whether it's that excessive ultraviolet exposure, an underlying microbial infection, medications, especially anti-glaucoma medications, lid abnormalities, infrequent blinking, exposure. I had a patient who recently had a brain surgery due to a brain tumor, and she developed this mild proptosis, and she had exposure. By just patching the eye with a skin tape, her cornea quickly healed within a week or 2. Also, we are in a digital era, staring at screens, smartphones, iPads. This concentration can reduce the rate of blinking, thus induce ocular surface abnormalities. So the aim is really to try as much as possible to use medications that are preservative-free to minimize the side effects of the medications. Nutrition is very important. In my practice, I see many patients, even young patients, who are anemic. And anemia can delay the improvement and the healing of the ocular surface disease. And now with bariatric surgery, abnormalities have become very common. I remember a patient who it took almost 2 months, persistent epithelial defect, heal because she had bariatric surgery and she was not taking her vitamin supplements. And by just discovering this and doing a vitamin profile and giving her the vitamin supplements that she needed, she immediately healed and the ocular surface improved. So early detection, aggressive therapy, and minimizing the side effects. So that's why we need to coordinate with a rheumatologist, internist, nutritionist to treat the underlying cause and to save the ocular surface. I remember one patient who had an underlying disease and she would just not heal, but once we addressed her underlying disease, the ocular surface immediately healed, but she had to take immunosuppressive therapy. So what are the various treatment options? We have the dry eye workshop 2 treatment algorithm. We have to identify the cause, as mentioned earlier. We have to educate the patient about their condition, the management protocol, and the prognosis. And educating the patient becomes part of the medical team. And this significantly improves the compliance of the patient to therapy because now the patient is aware of his condition. We have to modify the environment, as I mentioned earlier. We have to improve the nutrition, we have to clean the lids, and we have to apply more compressors and lubricants. And one of the useful lubricants for the evaporative type of dry eye is the lipid-containing supplements, and this has really been a game changer in the treatment of a certain type of ocular surface diseases. Instituting proper lid hygiene, as you can see here in this photos, the keratinization that can clog the meibomian orifices, and once these are removed, the flow comes back to normal, especially when accompanied by warm compressors. And the cloth needs to be significantly warm. It has to be around 45 degrees Celsius in order to create a 40 degrees Celsius warm lid. And you need to reheat this every 2 minutes. And this really softens clauses at the gland openings. Step 2 is trying different types of preservative-free eye drops. Punctal plugs, eye ointments, and moist chambers are quite useful. Also, then trying intense pulse light therapy. And what this does, it really mimics the warm compressors, and it can be quite effective. One session is like equivalent to warm compressors twice daily for 3 months. Masking probing is a really beneficial tool. I've tried this in a number of patients. Patients immediately improve within a week, but this can be quite uncomfortable, so you need to use a lidocaine gel on the eyelid margin before starting the procedure. But this really can unclog these clogged orifices. Also using antibiotics and steroids like azithromycin and tetracyclines, especially if there is an underlying secondary cause like ocular rosacea. So it has shown its benefits in experiments, but its clinical evidence has not really been, or it's been quite limited. Steroids, we know that there is an inflammatory component to ocular surface disease, as mentioned earlier, and using steroids can significantly reduce the symptoms and signs that are seen. But as we all know, that steroids do have their side effects of increasing intraocular pressure, cataract, and possibly opportunistic infection. But using it for like short periods and pulse doses can be a game changer. Topical secretagogues are medications that can induce the eye to produce mucin, and this was first introduced in Japan because secretagogues are used to treat peptic ulcers by secreting mucin in the stomach, and that heals peptic ulcers, so why not use it in the eye? And it was found to improve signs and symptoms. There are a number of these types of medications, but unfortunately this was not FDA approved because it failed to meet clinical endpoints. We have topical immunomodulators like topical cyclosporin. It was FDA approved in 2003, and I use this quite frequently. It can really treat and address both types of dry eyes. And it has shown that this even improves the patient's tolerance to anti-glaucoma medications. And it was found that the apoptosis-related markers were found to be decreased after using this medication. Now we have a high concentration, CEQA, which is 0.09. It has the highest approval. And this CEQA has what is called a nanomesicellular formation, where it has a hydrophobic core and hydrophilic shell, and this improves the penetration of the drug. and thus improves results of this medication. And now we have other brands available. Unfortunately, this is not available in Saudi Arabia. So what I'm doing in my clinic is preparing tacrolimus 0.001% in the clinic. So that's two zeros after the dot. And I've been using this in the quite resistant cases, and like graft versus host, Sjogren's syndrome, primary and secondary, and have been getting good results. Another immunomodulator is lifitegrast, and this is also has been FDA approved. And what the medication does, because there's ICAM overexpression in ocular surface disease, it blocks LFA1 with the ICAM at this point, and thus it relieves the signs and symptoms of dry eye. If that still doesn't work, then you can add oral secretagogues and topical autologous serum. The serum is really, really effective, especially in my country in patients post-trachoma, because they have damaged accessory lacrimal glands. And once you prescribe this medication, patients just become addicted to it. It's like mimics the tear film. So it improves signs and symptoms, and it improves the even staining once started. And it's, of course, better than the preservative-free artificial lubricants. Also, in step 3, we have therapeutic contact lenses, whether soft or rigid, and they are very effective for recalcitrant or resistant cases. These little contact lenses are quite large, and they extend and they reach the conjunctiva, so they cross beyond the cornea, and it collects a lake of tear film between the ocular surface and the rigid contact lens. So the contact lens basically hovercrafts over the cornea, and this really improves, and it covers the irregularity of the cornea, thus improves vision. But you need a skillful contact lens specialist for proper adjustment and follow-up. So these are very useful for the really bad types of ocular surface disease like exposure keratopathy, Sjogren's, neurotrophic ulcers, and graft versus host, and so forth. If all this doesn't work, then we can go to step 4, long-duration topical steroids, and I do resort to this. I give like 3 or 4 months. Most of these patients are usually pseudophakic, and there's less chances of increase of intraocular pressure. We can go to hemotic membrane grafting, and as mentioned previously, there's Procera. Procera has been really amazing. We have 2 types, Procera and Procera Plus. I usually just go to a Procera Plus because once you reach stage 4, patient does need aggressive type of approach. You can use surgical punctal occlusions, and tarsorrhaphy has really been amazing. I had a patient who I grafted and just failed to heal. Just by looking at him a week or 2 later, I found he just does not blink. He's got total loss of corneal sensation. And so by instructing the patient to intentionally blink and doing a lateral tarsorrhaphy, his cornea healed within a week. So let me go through this. I
am د.معن البري. I'll be talking about a case of corneal melting after PRK. A 47-year-old lady presented on the 18th of August 2016 interested in refractive surgery. History of underlying systemic or previous surgeries and medications were negative. She had simple myopic astigmatism in both eyes that best corrected to 20/20 vision OU. Slit lamp examination was unremarkable. She had acceptable corneal topographies on her right and left eye respectively. An eventful PRK was performed on the 24th of August 2016. Her epithelial defect failed to heal on the first post-operative visit 7 days later. So the differential diagnosis of a tight contact lens fitting, vitamin deficiency, and a rare possibility of bilateral hepatic keratitis was contemplated. So her contact lenses were discontinued. She was kept on a prophylactic topical antibiotic eye drop. Her topical steroids were reduced, and she was placed on aggressive topical autologous serum. She was also started on oral 1 gram vitamin C twice daily. Her epithelial defect still failed to heal, and she still had a large corneal epithelial defect in both eyes 7 days later. So her vitamin profile was ordered, and she was found to be vitamin deficient. So she was started on 0.25 micrograms twice daily of vitamin D. Procera Plus was placed in both eyes, which is a hemotic membrane contact lens. Her improvement was 0 on the right eye and 50% in the left eye 7 days later. And corneal melting began to start in both eyes 14 days after the Procare replacement. So imatic membrane transplantation was scheduled for both eyes, and her vitamin D level was again rechecked and remained to be deficient due to the patient's poor compliance with the medication. During removal of the sutures after implanting the imatic membrane a month later, she was severely thirsty during the procedure. So unveiling her, she was found to have a severe dry mouth, xerostomia, and her eye was also dry. So the diagnosis of Sjogren's syndrome was placed as a strong cause or differential. Her ESR and C-reactive protein was positive and elevated. She was rheumatoid factor positive, so she was referred to the rheumatologist with the possible diagnosis of Sjogren's syndrome, and that was further confirmed by the rheumatologist. Further blood tests were ordered to further confirm the diagnosis. On her last follow-up on the 28th of November 2016, her uncorrected vision was 2100 in the right and 2200 in the left. She was referred to a tertiary care center for commencement of antimetabolites such as mycophenolate mofetil and biologics such as Humira to stop the aggressiveness of her Sjogren's condition and the possibility of a repeat AMT.
So no matter how much you treat this patient, whether you go from step 1 to step 4, if you do not treat the underlying cause, the patient will just not heal, and the prognosis is going to go just all the way down. So this patient, I started this patient on mycophenolate mofetil, and I started her on adalimumab. I referred her to a tertiary center, and by the time she reached, friends there called me and they said she's already healed. Because once she was started and the underlying condition was treated, then the step 1 to step 4 became effective. The autologous serum, the AMT started kicking in, and the ocular surface just healed. So if you do not treat the underlying condition, you'll just get nowhere. And that was the lesson I learned from that case. And especially if you're contemplating to perform a refractive procedure, make sure the patient do the Schirmer's test, do the staining, the ocular surface staining, and make sure you exclude these patients from your list. So in conclusion, the ocular surface has an integrated unit of components, and it is important for the reasons I mentioned earlier. How to manage it is stressing that we have to treat the underlying cause, we have to address that nutritional deficiency, and then going through the 4 steps mentioned by the dry eye workshop 2 algorithm. And thank you for your attention.